Guys, Dr. Coucher, we're going to be talking about neurologic and neuromuscular agents for our patients with chronic and acute critical and mental health care needs. So let's start with talking about some stimulants. We need to talk about our nervous systems. It's just a little refresher that we're going to have just to remind us of what everything does. Central nervous system, or CNS. It says to the brain, spinal cord regulates body functions, interprets information sent by the peripheral nervous system. Stimulation of the CNS may either increase the nerve cell activity or block nerve cell activity. The peripheral nervous system, there are two divisions, the somatic and autonomic nervous system. The somatic, it is voluntary. It acts on skeletal muscles to help us move and to breathe. The autonomic is involuntary. It regulates the heart, the respiratory system, the GI system, and the glands. It further breaks down into our sympathetic and parasympathetic systems. So when we're talking about the ANS and the sympathetic versus the parasympathetic, the sympathetic nervous system is also called the adrenergic system because its neurotransmitter is norepinephrine. So its response is excitability. You're probably going to be like, oh my gosh, Coucher. The parasympathetic nervous system is called the cholinergic system because its neurotransmitter is acetylcholine. So its response is inhibition. It holds back. Our organs are innervated by both systems, and thus they can produce different responses. Numerous drugs stimulate our CNS. However, medically approved use of CNS stimulants is limited to treating ADHD or ADD, narcolepsy, and respiratory distress reversal. The major groups of CNS stimulants: amphetamines, they stimulate the cerebral cortex. Epileptics act on the brainstem and the medulla to stimulate respiration. The anorexiants thought to suppress the appetite. It just kind of helps you feel like I'm full. And that comes from the hypothalamic and limbic areas. So it just makes you feel I'm satisfied, I'm good. Amphetamines and anorexiants are often abused to a great extent. Long-term use of amphetamines can produce psychological dependence or tolerance, which leaves the person needing bigger and bigger doses in hopes of reproducing that initial response. Attention deficit hyperactivity disorder, ADHD or ADD, you have some without the hyperactivity. It's thought to be caused by dysregulation of the transmitters serotonin and norepinephrine and dopamine. Occurs primarily in children, and that is also primarily boys. May not be diagnosed in some cases until early adulthood. And girls, if they are diagnosed, may be diagnosed in middle school. If they're not exhibiting that hyperactivity that we're typically used to seeing, I'm sorry, I have two boys like that in my house. But I have a girl who's not hyperactive, but she definitely has problems with attention. She wasn't diagnosed until she was a teenager, and the others were diagnosed when they were young kids just starting school. There are various types. You have inattentiveness, inability to concentrate, restlessness, fidgety, hyperactivity, excessive and purposeless activity, inability to complete tasks, and impulsivity. Children with ADHD may have poor coordination and abnormal EEG findings. Intelligence is usually not affected, but they might have some learning disabilities. Narcolepsy is falling asleep during normal wake hours, such as driving a car or talking with someone. Then there's the sleep paralysis. It's the condition of muscle paralysis that is normal during sleep, usually accompanies narcolepsy and affects the voluntary muscles. So have you ever been asleep and you thought you were awake and you were having a dream, but you couldn't move your arms, you couldn't move your body to respond? The patient with narcolepsy is unable to move and may actually collapse. Amphetamines stimulate the release of neurotransmitters, norepinephrine and dopamine, from the brain and sympathetic nervous system, and they block the reuptake of these transmitters. They cause euphoria and increased alertness, xerostomia, that dry mouth, insomnia, restlessness, tremors, irritability, and weight loss. Excessive use may lead to psychosis. Its half-life is varied from 9 to 15 hours. It's a pretty big stretch of time. Side effects and adverse reactions: dizziness, headache, euphoria, insomnia, tachycardia, hypertension, palpitations, dry mouth, anorexia, diarrhea, and erectile dysfunction. Korean ginseng may potentiate drug effects, the drug effects of the CNS stimulants. So amphetamine-like drugs that are used for ADHD and narcolepsy: methylphenidate and dexmethylphenidate are classed as an amphetamine-like drug. It's used to treat those two. Increases attention span and cognitive performance, and to decrease the impulsiveness, hyperactivity, and restlessness. Do not take in evening time related to the risk of insomnia. Take drugs when waking up. Controlled substance schedule drug 2. It's a class 2 drug schedule, I should say. Modafinil is an amphetamine-like stimulant that increases wakefulness, and it's a class 4 one. So our amphetamines: amphetamine sulfate, dextroamphetamine sulfate, lisdexphetamine dimesylate, that are amphetamine-like drugs: methylphenidate hydrochloride, modafinil, dexmethylphenidate hydrochloride, and armodafinil. Other narcolepsy agents: histamine 3 receptor antagonist, patiselant, and then there is the dopamine and norepinephrine inhibitor, Sorifatol. Rimafatol. I love saying these names. Methylphenidate is most frequently prescribed drug used to treat ADHD. Well, absorbed in the GI mucosa. Food affects its absorption rate, so we want to give it when the patient wakes up or 30 to 45 minutes before meals. Given 6 hours or more before sleep due to the insomnia that it can cause. It is excreted in the urine. That is contraindicated for anxiety, Tourette syndrome, glaucoma, psychosis, hereditary fructose intolerance. It does have some drug lab and food interactions. So caffeine, chocolate, tea, colas may reduce the effects of antihypertensives and increase the effects of oral coagulants, barbiturates, anticonvulsants, and TCAs. Excuse me. It increases the hypertensive crisis with MAOIs. St. John's wort may decrease the drug efficacy. Side effects are anorexia, dry mouth, vomiting, dizziness, insomnia, irritability, restlessness, anxiety, confusion, depression, euphoria, hyperhidrosis, tremors, blurred vision. I mean, the list goes on. It's amazing that we give this drug out to our children. Anorexiants, they create a stimulant effect on the hypothalamic and limbic regions of the brain to suppress appetite. Most do not have the serious side effects associated with amphetamines. It is contraindicated in hypertension, hypothyroidism, glaucoma, and within 14 days of an MAO and therapy. It is given cautiously with diabetes, seizures, Tourette syndrome, and bipolar disorder. It should not be given to anyone younger than 12 years, and self-medicating is always discouraged. The most frequently prescribed out of it is phentermine. Epileptics, there are caffeine citrate and theophylline. Mostly they affect the brainstem and spinal cord, but they could have some effect on the cerebral cortex. Primarily used for analeptic primary use for an antileptic is to stimulate respiration. Caffeine is given to neonates to increase those respirations. Theophylline is used mostly to relax the bronchioles. Side effects would be from caffeine are similar to those from anorexiants. Other side effects include headache, GI irritation, urinary frequency. Excessive caffeine affects the CNS, heart, and can cause dysrhythmias and seizures. Half-life of caffeine is approximately 4 hours. Prolonged in individuals with liver disease and patients taking oral contraceptives or are pregnant. I always think that the half-life of caffeine in my body is probably way on out there because I have nothing but caffeine. Typically contraindicated in pregnancy due to the unknown effects on the fetus. So we need to look at our nursing process, our assessment, look at our problems, plan for this patient, intervene, and we need to teach. Seizure disorder, a result of abnormal electric discharges from the cerebral neurons. I was not going to erase that. It's just FYI, the last time I erased a slide, I erased every single slide that I had recorded. So y'all are going to get all my good vibes. Characteristics: loss of consciousness, involuntary uncontrolled movements. The cause is relatively unknown. 75% are considered to be primary or idiopathic of unknown cause. The remainder are secondary to like a brain trauma or anoxia, infection, or stroke. Isolated seizures can be due to fever, electrolyte or acid-base imbalance, alcohol, or drugs. Majority of persons diagnosed are younger than 20 years of age. Diagnosing is done with an EEG, CT scan, or an MRI. There are international classification of seizures. Common generalized seizure types are tonic-clonic, the grand mal. It's the most common. Generalized alternating muscle spasms and jerkiness. Petite grand mal, they'll have brief loss of consciousness for 10 seconds or less, usually occur in children. Common partial seizures, psychomotor, there's going to be some type of repetitive behavior, chewing or swallowing emotions, behavioral changes, and motor seizures that occur. Antiseizure drugs, also known as anticonvulsants or antiepileptic drugs, AEDs. They stabilize nerve cell membranes, suppress abnormal electric impulses in the cerebral cortex. Drugs are also classified as CNS depressants. The specific types of action, there are many there that suppress the sodium influx. Because the drug binds to the sodium channel when it is inactivated. And those are the phenytoin, phosphophenytoin, carbamazepine, oxcarbazepine, valproic acid, topiramate, and you'll see also the suppressive calcium influx drugs, valproic acid falls within that range as well. The calcium influx for these drugs is it prevents the electric current generated by the calcium ions to the T-type calcium channel, and that'll be the valproic acid and the ethosuximide. Now, the ones that enhance the action of GABA. GABA is gamma aminobutyric acid, and I am sorry that I butchered that name. But for short, we can call it GABA, and now you know what it is. But to enhance that acid, we're going to do barbiturates, benzodiazepines, and thiamine. And if we want to promote the release of it, then we're going to give the patient gabapentin. And we know that gabapentin is used for other things. It is used for pain management in patients who have long-term pain problems. Those folks that that have nerve problems. Using gabapentin, which is an anti-seizure drug, helps to stop the firing of those nerves in that injured area. Hydantoins, that's our phentoin, contraindicated in pregnancy because it does have a teratogenic effect. We do have to have a serum therapeutic level for this drug. Side effects are adverse reactions, gingival hyperplasia, nystagmus, diplopia, headache, dizziness, slurred speech, alopecia, purple glove syndrome, ventricular fibrillation, depression, suicidal ideation, hyperglycemia, GI distress, urine discoloration, thrombocytopenia, leukopenia, and Stevens-Johnson syndrome. The nursing process, again, we're going to assess, we're going to diagnose, we're going to plan, we're going to intervene. We need to look at all of that for our patient taking these medications and make sure, again, that we're getting our information of the different drugs and herbs that they might be using. Barbiturates, phenobarbital, their action to enhance that GABA acid activity. They use it in tonic-clonic, partial myoclonic seizures or status epilepticus. It does have to reach a serum therapeutic serum range. Side effects are sedation and tolerance, and the discontinuation needs to be very gradual. Succinimide, its action is to decrease the calcium influx. It wants to be given for absent seizures. And we're looking at a therapeutic serum range of 40 to 100 micrograms per ml. Adverse effects: blood dyscrasia, renal impairment, liver impairment, systemic lupus, and systemic lupus erythematosus. And then we have to look at our benzodiazepines, clonazepam, clorazepate, and diazepam. Clonazepam treats the absence of myoclonic seizures, and a tolerance may occur at 6 months when taken on a regular basis. Chlorazepate treats partial seizures. Diazepam treats status epilepticus. It must be administered IV for status epilepticus, though. Short-term effect: other anti-seizure drugs must be given during or immediately after the administration of diazepam. Carbamazepine, its use is for tonic-clonic or partial seizures, also used for psychiatric disorders such as bipolar, used in trigeminal neuralgia and alcohol withdrawal. It does have a therapeutic serum range of 4 to 12 micrograms per ml. It also has side effects and adverse reactions: dizziness, drowsiness, headache, blurred vision, GI distress, ataxia, weakness, and anemia. It does cause agranulocytosis possibly and Stevens-Johnson syndrome. There is a possible interaction with grapefruit juice, so maybe if our patient is on carbamazepine, we might want to have them hold off on drinking grapefruit juice for a while. I would hate to know that there was a possible interaction and go ahead and offer it to a patient. Valproic acid, it's used in tonic-clonic, absence, or mixed seizures. It also has a therapeutic range. Side effects: dizziness, drowsiness, insomnia, diplopia, weakness, GI distress, suicidal ideation, and thrombocytopenia. Anti-seizure drugs, something to kind of note about this: seizure episodes increase 25% in women with epilepsy who are pregnant. Many anti-seizure drugs are teratogenic, which I said on a previous slide, but the anti-seizure drugs tend to inhibit vitamin K, so it contributes to infant hemorrhage soon after birth. Vitamin K may be given during the last days of the few days of the pregnancy, or it could be given to the infant soon after birth, which we know is a standard. But I think that when we're taking care of a mom with a baby, there's a few extra things that we're going to do. Interesting to know, epilepsy develops in approximately 2.5% of children who have had one or more febrile seizure. I didn't realize that. Prophylactic treatment for high-risk patients is going to be the phenobarbital or diazepam. Status epilepticus is an emergency. Treatment must begin immediately. We're going to treat with diazepam and lorazepam, and we're going to follow it up with a phenytoin IV. For continued seizures, midazolam and propofol will be given, and then we want to do slow IV administration to avoid respiratory depression. Parkinson's disease. It's a chronic neurologic disorder, imbalance of neurotransmitters to dopamine and acetylcholine, degeneration of the dopaminergic neurons leading to a lack of dopamine. Dopamine is our our inhibitory neurotransmitter, and acetylcholine is the excitatory. Dopamine normally maintains control of acetylcholine and inhibits its excitatory response. But in Parkinson's disease, there's an unexplained degeneration of dopaminergic neurons, and an imbalance between the dopamine and the acetylcholine occurs. With less dopamine production, acetylcholine is then just completely unopposed. Characteristics: involuntary tremors of limbs, rigidity of muscles, bradykinesia, postural changes, shuffling walk, lack of expression, and a pill rolling motion of the hands. Treatment: anticholinergics, dopamine replacements, dopamine agonists, MAOB inhibitors, and CLMT inhibitors. Anticholinergics, their action is to inhibit the release of acetylcholine, reduce rigidity and some of the tremors, minimal effect on the bradykinesia. Side effects: dizziness, drowsiness, anxiety, headache, insomnia, paresthesia, restlessness, blurred vision, ocular hypertension, weakness, dry mouth, GI distress, and anhidrosis and urinary retention. So let's talk about some dopaminergics. When levodopa is used alone, only 1% reaches the brain because 99% converts to dopamine while in the peripheral nervous system. So we combine carbidopa with levodopa. Carbidopa can inhibit the enzyme decarboxylase in the periphery, thereby allowing more levodopa to reach the brain. So the combination becomes the carbidopa-levodopa. The action converts to dopamine and increases mobility. Side effects may be fatigue, insomnia, dry mouth, blurred vision, orthostatic hypotension, palpitations, dysrhythmias, GI distress, urinary retention, dyskinesia, psychosis, and severe depression. So dopamine agonist, amantadine, also antiviral drug for influenza A, interesting. Action: stimulates the dopamine receptors. Taken alone or in combination with levodopa or an anticholinergic, the side effects: dizziness, drowsiness, headache, confusion, nightmares, insomnia, anxiety, irritability, nausea, orthostatic hypotension, and peripheral edema. Monoamine oxidase B inhibitors, MAOB, sorry. Selegiline, the action is to inhibit MAOB enzyme that interferes with dopamine. You're going to have some side effects along with it, and then there's also food interactions. Foods that are high in tyramine can cause a hypertensive crisis in the patient. Acetylcholinesterase Inhibitors. These are our COMT enzyme. This is tocopon. Its action is to inhibit the enzyme that inactivates dopamine. It also comes with quite a number of side effects. Now, let's talk about our collaborative care, the nursing process for this patient. Again, obtain a health history, especially if the patient has GI dysfunction, glaucoma, urinary retention, angina, or myasthenia gravis. You want to look at their drug history. You want to look at what nursing diagnosis is most important for them. You need to plan appropriately, and you need to intervene appropriately. Alzheimer's disease, probably one of the saddest diseases out there. It's incurable dementia illness, chronic progressive neurodegenerative disorder, marked cognitive dysfunction. Onset is between ages 45 and 65. I had somebody describe Alzheimer's to me one time, and it was amazing the way she did. She said you take a book and you get to the very end of the book, and that is the time when the patient has been diagnosed, basically. And so the brain starts tearing pieces out of this book right here, and it goes from back to front, so that all of your primitive reflexes and tasks such as feeding yourself are the last to go. I really feel like this is the saddest disease out there, because they stop knowing who their loved ones are. And I watched a documentary made by a woman's son, and it's been some years ago. I used to teach in another course when I did the Neuro, and so he made this little documentary of his parents, and they stopped. The dad took care of his mom, I guess until the disease just got so bad he couldn't any longer. So they put her into a home, and every day he went to the home to visit with his wife. The dad did. They had not been apart in 60 years, and in fact, they grew up together, so they'd known each other their whole life. The only time they split apart was when he was in the service. So anyway, he used to go there every single day and hold her hand and dance with her. And some days she knew who the nice young man was that came and held her hand and danced with her, but other days she didn't know, and she just hoped that she wasn't doing anything wrong. I think that's really quite special. Alzheimer's disease, the symptoms with it: memory loss, confusion, inability to communicate, aggressive behavior, depression, psychosis. The progression leads to loss of memory, their logical thinking, their judgment. Then they lose time, become time disoriented. They have personality changes. They become hyperactive, tendency to wander around, inability to express themselves, and later they might have some hostility or paranoia. Acetylcholinesterase and cholinesterase inhibitors. This is rivastigmine. The action: allow more acetylcholine in the neuron receptors, increase cognitive function, and slow the disease process. Does come with side effects just as any other drug: dizziness and headache, confusion, depression, dry mouth, GI distress, dehydration and weight loss, bradycardia, hepatotoxicity, Stevens-Johnson syndrome. Nursing process, we're going to assess our patient's mental and physical abilities, obtain a history. We want to do a nursing diagnosis, self-care deficit, confusion, plan. The patient's memory may not be improved. It may stay kind of where it is, but it's not going to be improved. Patient will maintain self-care with assistance, so they might need prompting. Maintain consistency in care, record vital signs, observe any patient behavioral changes and note any improvement or decline. Teach the family members about safety measures to avoid injury when the patient wanders. Myasthenia gravis, the pathophysiology of it is an autoimmune disorder. Antibiotics attached to the acetylcholine receptors obstruct binding of the acetylcholine and destroy receptor sites. Lack of acetylcholine impairs transmission of messages at the neuromuscular junctions. It leads to ineffective muscle contraction and muscle weakness, leads to weakness of respiratory and facial extremity muscles. Characteristics: skeletal muscle weakness, fatigue, ptosis, dysphagia, dysarthria, respiratory muscle weakness, paralysis, and arrest. For a crisis, a myasthenic crisis, it's severe generalized muscle weakness, involves the diaphragm and the intercostal muscles. The triggers for it: inadequate dosing, emotional stress, menses, pregnancy, infection, surgery, trauma, hypokalemia, alcohol intake, temperature extremes, and medication interactions. We want to treat with neostigmine. If untreated, it may cause death from paralysis of the respiratory muscles. So a cholinergic crisis usually occurs within 30 to 60 minutes after taking an anticholinergic medication. It is usually triggered by overdosing. Symptoms: severe muscle weakness, possible respiratory paralysis and arrest, abnormal pupil constriction, pallor, sweating, vertigo, excessive salivation, GI distress, bradycardia, fasciculations, that's involuntary muscle twitching, and it worsens after hydrophonium. Sorry, I pronounced it bad. Cholinergic crisis is caused by continuous depolarization of postsynaptic membranes that create neuromuscular blockades. So we don't want to overdose and we don't want to underdose because it will have the similar symptoms. Uh, Myasthenia crisis may be caused by underdosing, and cholinergic crisis will be caused by overdosing. So we have some short-acting, intermediate-acting, and long-acting anticholinesterase inhibitors. The action, though, is to increase muscle strength in patients with myasthenia gravis. Side effects: they're going to have increased salivation and tearing, meiosis, blurred vision, bradycardia, hypotension, GI distress. Patients who do not respond to ACHE inhibitors may require additional drug treatment with prednisone, plasma exchange, IV immunoglobulin, or immunosuppressant drugs. Prednisone is the drug of choice. It reduces the presence of antibodies. It does not produce a permanent immunity. Long-term side effects, though, are significant. Azathioprine is an immunosuppressant agent used in conjunction with prednisone. Monitor the complete blood count for the first week, twice monthly for the second and third months, and then serum amylase thereafter. Anticholinesterase inhibitors and our nursing process: assess for signs and symptoms of myasthenia crisis, such as muscle weakness with difficulty breathing and swallowing. You want to diagnose the patient with breathing pattern ineffective. Then you want to plan for them and you want to intervene for them. Administer doses on time. That's a big one. Encourage the patient to wear medical identification. And we want to reevaluate our plan. Multiple sclerosis. It's an autoimmune disorder. It attacks the myelin sheath of the nerve fibers in the brain and spinal cord and causes lesions. Those are plaques. Characteristics, remissions and exacerbations, weakness or paralysis of extremities and fatigue, muscle spasticity, paresthesia, dysarthria, dysphagia, ataxia, diplopia, blurred vision and vertigo, and tinnitus. Usually it is more common in Caucasian females 20 to 48 years of age. It may affect the bladder and bowel while causing sexual and cognitive dysfunction, and there is no known cure for it at this time. We have different classifications: relapsing, primary, secondary, and progressive. Relapsing, relapse with full recovery and residual deficit. Primary is going to be slow worsening neurologic function. Secondary, initial course is relapsing, remitting. The progression with or without occasional relapses, minor remissions, and plateaus. Progressive relapsing, progressive from onset with acute relapses with or without full recovery. Immunomodulators, these are DMDs. These are the disease-modifying drugs. They're the first line of defense. They slow the disease progression and prevent relapses. It modulates the course of MS either as an immunosuppressant or immunomodulator. If it's an immunomodulator, then we're going to use beta interferon, glatiramer acetate, teriflunomide. Immunopressants, then we're going to use methoxytrone and dimethyl fumarate. Please don't kill me on my evals. Skeletal muscle relaxants. Centrally acting muscle relaxants. They relieve muscle spasm and spasticity. They have a sedative effect. Crispidol or Soma, chlorzoxazone, methocarbamol, metaxalone. These are all some drugs that we can use. More commonly used than those is a really mild one, and it's Flexeril. It's direct-acting muscle relaxant. Is diatenolone. It decreases the muscle spasm and increases the range of motion. Side effects include drowsiness, dizziness, headache, nausea, and vomiting. Okay, so cyclobenzaprine, Flexeril, its action is to relax the skeletal muscles, relieve muscle spasms. The side effects of it are going to be anticholinergic effects. So they're going to have blurred vision, dry mouth, tachycardia, urine retention, constipation. They may have drowsiness, dizziness, headache, nervousness, GI distress, unpleasant taste, and dysrhythmias as well. So what do we need to do for a nursing process? We need to assess our patient. We need to obtain all that history, including the drugs. We need to look at our nursing diagnoses. If we're doing Flexeril or one of these muscle relaxants, then we know that they probably have some impaired physical mobility. We want to plan for the patient as well. We want to intervene, and we want to reevaluate the plan that it worked. You can refer to your patient-centered collaborative care in the book. That's the end. Stay tuned for your assignment of the discussion board.